So I'm going to talk to you a little bit about Hangman's fractures. I'll acknowledge one of my colleagues, Brandon Lawrence at University of Utah. I borrowed a couple of his slides. So a little history of the Hangman's fractures. It's got a very interesting name, obviously, a little bit morbid. The fracture was termed by Robert Schneider in 1965. And what he noticed was that in high-speed car accidents, some of the fractures that they were seeing resembled the type of injuries that they knew existed in judicial hangings. Hangings have been with us since the Roman times, the Roman Empire, but sort of the standard drop hanging as a form of execution was really not introduced until around 1866, and it was modified after that. Originally, they would put the knot either behind the head or on the side. The problem was is that the person being executed was often decapitated. So they moved the knot anteriorly under the chin, which created a severe forced hyperextension distraction injury that severed the spinal cord, causing immediate death without decapitation. And that's really the mechanism that we see for most of these hangmans. It's probably not as severe as hanging, but it's a forced hyperextension injury and distraction. Even though it results in death with hanging, most of the people that we see from motor vehicle accidents come in neurologically intact. The force is probably not equal. There are probably patients that suffer this injury in a motor vehicle accident that die at the scene that we don't see, but the ones that arrive in the hospital are more often than not neurological. I'm going to show you a case, and we'll work through this case a little bit as we work through the talk. This is a 56-year-old male driver, high-speed motor vehicle accident, whose only neurological complaint was paresthesias in his hands that kind of persisted early in his hospital stay, as you'll see, but he was otherwise neurologically intact. You can see his fracture pattern. All these have a little bit of atypical variance, but you can see the bilateral fractures through the pars interarticularis, and this one has a little bit of fracture also into the lateral mass of C2. So as part of this talk, we'll talk a little about classification. We'll talk about treatment options, some of the evidence that supports the options, and you'll see this evidence is really not all that great and a little bit scarce, and we'll talk about how we handled this particular case and why. So the classification we use most frequently is the Levine-Edwards classification. It was really initially the Levine classification, and it's basically a type 1 fracture is essentially a non-displaced fracture, minimal angulation, less than 3 millimeters translation. A type 2 is basically a displaced fracture. It has greater than 10 degrees of angulation, greater than 3 millimeters translation. You'll see there's a huge variation in these type 2 fractures from just barely a type 2 to a much more severely displaced type 2. And I think this is one of the problems when we see the literature, when we look at this, is that that's a wide body of classification. The type 2A is the thing that makes this different than the Effendi classification. I'll show you in the next slide. The 2A fracture is probably more of a flexion distraction injury as opposed to an extension injury. There's minimal translation, more angulation. And I'll show you an example of why that separate classification was important. And then lastly, type 3 is a very specific injury. It's a Hangman's fracture with bilateral C2-3 jump facets. It's thought to be a flexion injury followed immediately by an extension mechanism. The Effendi classification really was almost the same, except that the 2A doesn't exist. And there was some thought that the 3, again, was a flexion extension injury. The 2A injury became important because we often reduced these in cervical traction and we would place them in a halo. This is how we handled them for many, many years. If you notice, this fracture pattern is more horizontal. There's quite a bit of angulation, but almost no translation. And the problem with this injury, if we tried to put it in traction to reduce it in a halo, it would over distract. So it was very important to recognize this, Today, we almost never treat these in cervical traction and rarely a halo, so it becomes a little bit of a moot point other than recognizing this is a different mechanism of injury. So the type 2 is probably one that we have the most controversy about. The traditional treatment was to reduce it in traction, put it into a halo, and treat it in a halo for 12 weeks. We use the halo less and less than we used to, but because of its own complications. And so quite often when we're thinking this would require a halo, it's so displaced, often surgical treatment's considered. And there are three options. One is direct osteosynthesis. The second is a posterior fusion, which spans from C1 to C3. Fixing into the posterior elements at C2 doesn't control the fracture. So you have to span up to the C1 level. And then an anterior cervical disc infusion at 2-3, which has seemed to have become a pretty popular option. So this is just an example of a case series on direct osteosynthesis. And you'll see as we go through the literature, the literature that has the most patients are all evidence-based. They're all meta-analysis. They're basically collections of these papers with smaller case series. So in reality, the literature is an abundance of case series. And in this study, they had 15 patients. The Hangman's fracture is not common enough. And certainly the ones that have a pattern that's amenable to direct osteosynthesis is a relatively small number. So this is actually a pretty decent case series. And ideally, what we'd like to do is lag the fracture, just following good AO fracture principles. The interesting thing about this is it's gaining a little bit more traction, and there are now some studies, and these are really 1 and 2 cases where people are starting to use navigation and minimally invasive techniques to place the screws rather than an open incision. And these are starting to appear in the literature and may generate some more enthusiasm. This is just an example of one we did recently, 22-year-old male. He was a multi-trauma from an MVC, type 2 fracture. You see, it's a fairly displaced one, but not terrible. But the fracture pattern itself appeared to be amenable to direct osteosynthesis. We actually started this case with navigation, thinking we would navigate, which seems to be useful. But the problem with it is it's hard to control the fracture in the body of C2 at the same time. And we actually converted this over to just inserting our screws with fluoroscopic assistance. And then we did an O-arm spin, and you can see the position of the screws and how it pretty nicely reduces the fracture and controls the fracture. This is 3 months post-operative visit on that patient. You can still see a little bit of angulation. The other choice that seems to be popular is a direct anterior cervical disc infusion. And again, these are mostly case series. This is a case series, just an example of 30 patients. And we'll talk about some of the potential problems with that. The last option that is really kind of the technically easiest one and an easy fallback option is a posterior C1 to 3 fusion. The problem with this is it eliminates the motion at C1-2. So people lose rotational motion, particularly the young patients. If I was going to use this technique, because Hangman's fractures heal quite well, and once they heal, they're stable, you could consider this form of instrumentation without fusion at 6 months. Use a CT scan, verify healing, and then remove the instrumentation to remobilize the spine. We use that strategy not infrequently now with complex upper cervical fractures. So you'll see here, I'll show you just some of the larger literature, and you'll see it's all systematic reviews, meta-analysis. This review was included 32 articles, but if you notice, a lot of these articles go back a long time. 6 of them were prior to 1980. And so to get enough patients for these articles, they really go back pretty far. They ended up with 357 patients. And what you'll see is most of these were treated non-operatively, because traditionally, this fracture has been very amenable to non-operative treatment. But again, it was often a halo. And there's not a lot of granularity in these studies. And so that's one of the problems. And it shows you the distribution of fixture. But you can see that no matter what the fracture pattern is, it was more likely to be treated non-operatively, with the exception of type 3. A type 3 fracture, I'm not sure how you can reduce the 2-3 facets. It's unlikely that they'll reduce non-operatively. So you can see those are the ones they tended to treat non-operatively. And this is the distribution. Heavy favor in terms of non-operative treatment. The same paper showing you the classification, distribution of a non-operative treatment, and then the healing rate. And so if you'll notice, the healing rate of this fracture is really quite high. These are the ones treated surgically, and this is the type of approach they use. And I find it interesting that there was a fair number of patients treated with an anterior approach for a type 3 fracture. They must have been able to get the facet dislocations reduced, because type 3s I usually treat non-operatively. And you'll see the healing rate is quite high in these fractures with non-operative as well as operative treatment. This paper is another systematic review, and these articles were all from 2000 and onward. So this is a more modern paper. It had 548 patients. And in this paper, there was a heavy preponderance of operative treatment. The shift was sort of operative as people quit using halos as frequently. And if you look at the non-surgically treated fractures, the union rate was 94%. These fractures heal non-union. I don't personally know that I've ever treated a non-union from a Hangman's fracture. And if you look at surgically treated fractures, the non-union rate slightly higher at 99%, but again, both fairly successful forms of treatment. So in this fracture, they point out that these are, case series. They were unable to really substratify based on fracture subtype, but they felt like the more stable injuries did very well with non-operative treatment, and the less stable did well with surgery. The problem with all the papers that say that is, where do we find the difference between stable and unstable? And that's not always a clean line. It may include other factors such as the multi-trauma, the speed of the accident, the age of the patients. And there was no real difference in surgical approach in those series. This is a type 3 fracture. This is very unique. They're very uncommon. If you can do a closed reduction or an anterior reduction and get the facets to reduce, you can obviously treat it non-operatively, but most of these require an open reduction. In this one, we were able to do a direct osteosynthesis of the fracture and then a posterior C2-3 fusion. So the Hangman's variant are very interesting. They make us all a bit nervous because the ring stays intact. The reason these often are intact is because the C2 ring spreads open, creating more room for the cord. In the Hangman's variant, it'll behave more like a jump facet, where the two rings, as they translate, can cause cord compression. So our fear is always Nordjaw. There's actually a pretty decent paper specifically comparing typical and atypical Hangman's fractures. They developed a bit of a classification for the atypical fractures. The fear is obviously if the ring is intact and you see this posterior wall and the fracture pattern didn't occur through the pars, but slightly more anterior, the concern is the ring shifts forward, it can potentially pinch the cord. In this paper, and again, it's case series, the vast majority of these were treated non-operatively. If you notice in the type 1s, there was only one patient that failed halo treatment and surgery, and as best I can tell, they didn't develop a deficit as we would be concerned about just simply fracture displacement. So they felt like for conservative treatment of Hangman's variant, there were 63 patients, all progressed to union. This makes sense because the surface area is better. There was no conversion to surgery other than that one patient. And they didn't find any difference between the halo and collar treatment and felt it was safe for the less severely displaced fractures. This is a paper more recently. If you notice, this paper is from 2023. It's another systematic review just looking at operatively treated fractures. And their conclusion is not very robust. They basically said that any of these forms of surgical treatment can be effective. They have differences, for example, lower blood loss with the anterior than posterior surgery. They looked at some MIS treatment of fractures and felt that they may improve the outcomes of posterior approach, but it's mostly things like blood loss or infection, as you might expect. But they didn't compare it to non-operative treatment. So if we look at the difference between a collar and a halo vest, what we found is most type 1 and most type 2s can be treated non-operatively, and typically we would use a collar now in those patients. The 2As and the 3s are more apt to benefit from surgery and require surgeries. If the C2 fracture is amenable to a lag screw, that's my preferred form of treatment because it's direct fracture fixation. If that's not possible, that's when I consider an ACDF or a posterior cervical instrumentation without fusion. But stable injuries do well with rigid immobilization, and unstable do well with surgery. That's the only conclusion we can reach, but the problem is how we define unstable. And beware the Hangman fracture variant, but if we see from that paper, it's a pretty interesting conclusion that most of these can be treated non-operatively and heal quite well. So what about our patient? What's our next step? So here's our initial x-ray. Here's our initial x-ray in the upright in the collar. The problem is the paresthesias in his arms persisted the next day, which made us concerned that maybe he did have a cord injury. So we did an MRI. We didn't really see much in the way of cord injury here. You can see a lot of edema anterior to the vertebral body. And the 2-week x-ray, he started to displace anteriorly. So we felt this was a potentially unstable injury, persistent paresthesias, demonstrating some displacement on serial exam, although not severe. So then we just had to decide, are we going to continue this in a collar, switch to a halo vest, which might better control it, ACDF, or some type of posterior fusion. And for this patient, we opted for an ACDF. And you can see a little residual translation. One of the problems with the ACDF is it's very high in the cervical spine. The access is challenging, and the fixation is limited. The fixation in the body of C2 with vertebral screws is not robust. In some of these, we even consider doing bicortical fixation and grabbing the posterior cortex at C2. So swallowing problems and dysphasias, I think the biggest problem with C2 in your elderly patients, that's even a bigger issue. This patient did fine at 6 months follow-up. So in summary, Hangman's fractures are relatively uncommon. So our literature, we don't have good comparative literature. Most of our literature is based on these case series, and any of the larger papers are just collections of the case series, and it's a little hard to get good granular data on that. Most will fit into a classification. The C2 fracture or the displaced fracture has such a wide range from just say 4 millimeters of displacement to 10 millimeters of displacement that it's hard to parse out which fractures are really unstable and which aren't. Most of these fractures can be treated non-operatively. Seems to me we've gotten a little too aggressive, and I think that happened as we moved away from halos. But the papers, as you see, don't show a lot of difference between collar and halo treatment. So perhaps we can still treat a lot of these non-operatively in a collar, and I generally will try to follow that route if I can. The fractures do heal, and there aren't a lot of late complications once they heal. My least preferred method is a posterior fusion because of the loss of motion. But if we use instrumentation without fusion, let the fracture heal and remobilize, that's certainly a very viable option. If the fracture is amenable to direct fracture fixation, that to me seems like an ideal way. One of the things we haven't talked about a lot here is vertebral artery injury. These fractures, because they often invade at least one of the transverse foramen, they meet criteria for a CTA. So quite often as we're being consulted, the CTA is already done. I don't find that they have a lot of vertebral artery injuries, and your facilities probably have their own protocol how they handle those patients to show that injury. In ours, they just put them on aspirin. They don't really do anything. Sometimes they'll do a repeat CTA down the road. I think where it becomes important is if you're going to do a direct osteosynthesis on one of these fractures and one of the vertebral arteries is out or has no flow, The direct osteosynthesis, one of the biggest risks is putting the vertebral artery at risk with the screw. And so in that particular patient, you may be a little bit more hesitant to do direct osteosynthesis for fear that you would knock out the other vertebral artery and create a bilateral vertebral artery injury, which obviously is not survivable. The ACDF probably is the most common approach, at least right now in the US. People are familiar with it. They can leave the patient supine. The problem is there are a lot of swallowing problems, and the fixation at C2 is often not all that great. It's hard to get your plate to sit on right, but it is probably the preferred operative approach in the US at this point. Thank you. We can take some questions.
Thank you very much for the wonderful presentation. It was interesting as well as very difficult in mostly patient selection. So this is probably will be my question. How do you select the patient according to the age? So if we talk, motor vehicle, car accident are mostly preferred for young generation. So they are around 26 or 30 years old. So if you have this kind of patient, how would you manage him according to the surgical management? Thank
Yeah,
you.
the younger patient, where I really want a good alignment to control it. Quite often those patients have other injuries, and I think it's easier to follow them and control them if we do some type of surgery. So, in the type 1s, I'm treating in a collar regardless of age. In the type 2s, the more displaced it is, obviously, the more apt I am to treat it surgically. I still treat a lot of those conservatively. If it's an isolated injury, I'm probably going to err on non-operative treatment and follow it radiographically. In the multi-trauma, I'm going to probably be more apt to fix that particular fracture. In the elderly low energy fractures, though, we had one, for example, a week or two ago that was a 92-year-old fell, struck her head, and she has kind of a type 3 odontoid in combination with a Hangman's fracture. All of it pretty non-displaced, but we'll treat her for sure in a collar. It's low energy. I don't think it's likely to displace. There's a lot of surface area for healing, and we'll monitor her pretty closely. It would have to displace a lot for us to do something. The interesting thing is it's hard to find anything in the literature of these displacing and causing a deficit. So what we're really looking for, is it going to displace enough to cause late pain or other problems? Developing a deficit is not common. So the elderly patients, I'm very apt to treat non-operatively.
Thank you. Anybody has questions? Let me see what we have in the chat. We don't have questions. Probably the topic is so difficult.
It
Dr.
really
Hassan,
is,
maybe.
because when I look at these fractures, it's hard to decide. What I notice is some of my colleagues very aggressive. They're operating on them all for fear that it's a highly unstable fracture. But unfortunately, one of the things fortunately, one of the things that happen as we get old is we were around when we never operated on them, and we realized that most of them did perfectly fine. The problem was we put a lot of them in a halo. So the question is, can they do equally well on a collar? And the case series would seem to indicate that you can treat them non-operatively in a collar. And so I'm still very apt. Whereas my younger colleagues, when they see the fracture, it's uncommon enough that none of them have seen a lot of them. It takes a lot of years to accumulate a lot of these fractures. And so they're very afraid of it. Maybe because of the name, Hangman's fracture. Maybe if we just called it a C2 pars fracture, they wouldn't fear it so much. But I think when you call something a Hangman's fracture, it implies that, death is imminent unless it's treated aggressively.
Agreed. Sir, you can stop sharing your screen, and we will continue this discussion. Thank you. Yes, Professor Hassan, would you like to add something or your comments?
I asked a question in the chat part. Can't you see it?
No, second.
Nargize?
Thank you for your wonderful lecture. How much bone do you need anterior to the fracture line to use posterior moving, preserving screwing?
That's a really good question. And I don't know that I have a number for it. Some of these are very comminuted. And usually there's enough bone anterior. The problem is the posterior bone. Can I find a starting site that allows me that the head of my screw is not going to crack through? So really I'm looking mostly at how much bone I have posterior to the fracture, how much comminution there is. And I think the harder part is finding enough room posterior. And the other part is how, if I can angle the screw medial enough, I usually can get enough purchase in the anterior bone. This is where navigation may be able to help because it allows us to really put our hand out more laterally and get a much more medial trajectory. I'm not a great navigator. My younger partners are. So I still tend to do most of these freehand and fluoroscopically, but I think navigation is what allowing us to be a little less invasive in our surgical approach.
In some fractures passing through the corpus, C2 corpus, sometimes there is a little bone on the anterior part, sometimes 4 millimeters or 5 millimeters.
Yeah.
Do you try anyway in these cases to screwing anteriorly?
Yeah, so I will try to, if I have that situation, I'm definitely going to try to put the screw in bicortically and grab the anterior cortex. And to do that, you have to be obviously very careful, but I try to go bicortical in those situations. Usually my pedicle screws, just for deformity or other reasons, I'll quite often go bicortical anyhow, but you have to be very careful, obviously.
Thank you very much.
Thank you. Any other questions or comments?
Maybe Professor Bektaş want to make a comment.
Thank you, Professor, for sharing your experience and giving an excellent lecture. Thank you very much. I have some questions. The main difficulty, according to me, in the anterior approach is the location of pharynx. It's very hard to separate pharynx from the bone tissue, and also it's very hard to put the bone graft in between the disc area. Sometimes, although you make a discectomy, there may be a fusion after surgery. And we can only put the screws and the plates a bit laterally, not just in the middle. That's the problem. And I wonder your experience in making dynamic radiography, X-rays or dynamic MRI after trauma.
So my feeling is, if I've identified a fracture and I'm, there's a fracture that exists, I generally don't use flexion extensions. So if I'm on the fence about treatment and deciding is this unstable or stable, I'll put them in a collar and I'll do upright x-rays. And I'll sequentially follow them with upright x-rays at, initially 1 week, 2 week, and I'll look for displacement that way. But usually if I have a fracture, I don't flex and extend them. But at the end of my treatment, usually at 3 months, I'll use flexion extensions to assess stability when I'm removing the collar.
Thank you. Thank you very much.
Okay, Nargize, I think we finished all the questions.
Yes, sir. So
it was a
there is
wonderful
no
lecture
comments.
for me. I understood many views, angles of this chapter. Thank you so much, Professor Franz.
You're welcome. I'm happy to. Thank you very much for inviting me.
And I want to thank everyone who joined us today.
Yes,
Thank you.
thank you so much.
Enjoy the rest of your day.
Thank you, Professor. Yes,
Bye-bye.
see you next Monday or Saturday or Tuesday, whenever we decide to do second rounds. Thank you so
Bye-bye.
much.